So strong evidence to support uh, direction-specific exercises for folks who either centralize or peripheralize symptoms with repeated motion. So, for example, if someone demonstrated centralization of symptoms from going down to the foot and ankle towards just the knee area, with repeated flexion. We might have the patient go through an exercise where they go through repeated flexion motion. So, for example, having the patient in quadruped and go through the angry cat position of the cat cow. So, in quadruped, having the patient flex the lumbar spine to arch up and then come back to a neutral position in repetition. Or if patients respond well to repeated extension or repeated rotation in one direction or lateral flexion in one direction, having them do that regularly throughout the day. And generally speaking, tend to stick a little bit more towards flexion and extension based exercises with folks. It seems like a lot of folks tend to have centralization or peripheralization in those directions, but every once in a while I've come across someone who really responded well to a lateral flexion or rotation movement and geared more towards that. I'd say it's been less frequent than flexion and extension though, generally speaking overall. And this being strongly advocated for any chronicity of symptoms, either in the acute or subacute or chronic phases. Now, interesting study here essentially found our folks who had exercises matched to their directional preference uh, demonstrated diminished pain and medication or need for medications when compared to folks who just had general lumbar stabilization exercises. So just an interesting study here that compared what happens when folks have exercises that gear towards their directional preference versus just generalized lumbar strengthening exercises. So again, when your folks come in who demonstrate centralization with repeated motions, really honing towards that particular motion can be really important for these folks. Now, really controversial here are traction intervention here. So note one recommendation, again, conflicting evidence with this overall, but one recommendation not to use is with folks who have acute, subacute, or chronic low back pain. So not just for the back pain here. We're talking about folks with radiating radicular pain. So those folks that fit more into this classification here of our radiating pain more so. And even there, still conflicting evidence that we're seeing with this. So some evidence supporting the use of traction, some showing no improvement whatsoever with traction. Really just not a strong consensus on the evidence related to this. And nerve mobilization exercises. So moderate to low strength with this. And this is one of those intervention strategies that personally I've seen folks respond well to when when they're identified appropriately. So once we actually get our positive slump or our positive straight leg raise, and we identify those folks accurately who have a lumbar origin of their lower extremity symptoms, gearing towards these exercises can be especially beneficial. I've seen folks respond really well. And this can also be that population that lights up really badly if you're too aggressive. So it's really important to make sure that the patient's able to demonstrate our nerve mobilization exercises within an appropriate range and to know how to modify exercises if symptoms worsen or continue as they're going through an exercise. That's the patient that flares up that you're unlikely to see back in the clinic again, and therefore unlikely to be able to address their symptoms. So as you can see here, there's different positions that are described. We can have our patient in this position down in the left here, left bottom corner, where we've got kind of a modified straight leg raise there, and they're moving the foot and ankle through plantar flexion and dorsiflexion. So if we wanted to see a flossing technique or a gliding technique, we might see them flex the neck as they plantar flex the ankle, and then come back to neutral as they dorsiflex if we're trying to get a glider. Our top right picture, we see knee movement. So really any component of that chain with our progressive neurodynamic tension test. So we talked about how to sensitize with hip adduction, with our ankle dorsiflexion. Going through those different sensitization maneuvers, we can correspond exercises for the patient. And it can be helpful to have the patient go through to the point where they get their symptoms and then back off from there. So we know we're going to the point where we're going to be effective, where we're getting towards that restriction, but not past the point where it's becoming symptomatic. So on the bottom right here, we can see the patient in standing and going through a flexion as the ankle is plantar flexed and back to neutral or extension as the patient dorsiflexes, so a gliding technique. Now, if we wanted to do a tensioner, we can just have the patient look down as they dorsiflex and come back to neutral as they plantar flex. And with this nerve mobilization, like we've talked about in prior slides and last semester, can be passive. We can passively take them through those progressions, or can be active. And we'll be active with the exercises that hopefully we're giving these patients. Now, another position that's common is in sitting. So just having the patient sit, extend the knee out that's symptomatic, and just like with the slump test, have them put the arms behind the back and look down as they plantar flex, or come back to neutral as they dorsiflex, and go through that flossing maneuver there.